All right. So the next part of our session today is now, next po, is something to supplement our clinical skills. So if you notice, half the part of our session is really QI focused, but coming off from the reactions, recommendations, and insights from what we discover are ideas that we can now support with didactics. So Mika, can you put this in presenter mode so I can show the case? Yung slides mo. Kindly present it. Right, okay. So let me share with you a case that was shared by Dr. Mark Christopher Pasayan, who is one of our local mentors. This case is something that will jumpstart our didactic session that will follow. The didactic session will be led by our partners from UCSF, Dr. Emma Bainbridge and Dr. John Szymowski. So for today's case, next please. We have a 28 Filipino male MSM with multiple sex partners. He was diagnosed with HIV infection through voluntary counseling and testing in 2015. He was asymptomatic and had no signs and symptoms of advanced disease. His baseline CD4 was 330 and was started on tenofovir, lamivudine, and efavirenz, or LTE. He failed to seek follow-up consults and diagnostics and was on and off on his antiviral medications until he eventually stopped taking his regimen in 2016. After 2 years, he decided to follow up for the routine lab tests, and he was assessed to have presumptive pulmonary tuberculosis and was advised sputum examinations. Treatment adherence counseling was provided. However, he did not follow up and refused to be on ART. Again, after 2 years, he visited the clinic to get a medical certificate to avail of financial assistance. At that time, he complained of loose stools and unintentional weight loss. Repeat CD4 was 160. LTE, his previous regimen, was resumed, and cotrimoxazole prophylaxis was started. Again, adherence counseling was provided. Next, please. A month after, the patient now complains of a 3-day history of productive cough and nasal congestion. He denied fever, headache, and difficulty of breathing. He had follow-up consult and was assessed with upper respiratory tract infection. At this time, he was found to be adherent to his ART and COTRI prophylaxis. However, because of the COVID-19 lockdown, he did not do a repeat CD4 T-cell count nor an HIV viral load. On November 2021, he was able to seek consult through telemedicine. He admitted to be non-adherent to his ART. His repeat CD4 is now 14 and a viral load of 749,000. Genotyping was done and revealed the following. Okay, so I'll just give you some time to look at it, but if you can see, there's a lot of resistance even with the protease inhibitors. He's susceptible only to darunavir, tipranavir, zidovudine, and doravirine. And as you know, what's available locally is zidovudine. We do not have any data on the lopinavir, ritonavir resistance from this particular result. Next, please. The issues presented by Dr. Pasayan are the following: non-adherence to medication leading to HIV drug resistance, psychosocial or mental health issues, including the patient's denial of his HIV status, being lost to follow-up due to the COVID-19 pandemic, and what ART regimen to give the patient given the drug resistance results and given the patient's non-adherence history. Next, please. And now let me turn you over to our subject matter experts, Dr. John Chomowski and Dr. Emma Bainbridge, to continue our discussion. John, Emma?
Hi, everyone. LD, are we driving the slides, or is the team there driving the slides? Perfect. Okay. Good morning, everyone. It's evening time over here. It's our pleasure to join you for this discussion, and thank you for sharing this case. I think that it illustrates common dilemmas that you all are facing often, and I look forward to hearing your insights into how you manage these patients, and hopefully adding to that a little bit with whatever data that we have on in the literature. So let's get going. Next slide, please. So this case summary was just presented, so we can sort of skip through this. Next slide, please. So the initial genotype that we received had some interpretation of the resistance. We were able to get the actual mutations because that will, I think, enrich our discussion. As we've discussed in other meetings, there's some variability, I think, in how you are receiving genotype reports when you do receive them. And it sounds like sometimes they are including mutations and sometimes they are not. But there's a lot more that we, I think, can discuss if we have that extra data. So we have it, and we'll share it now. So here's the major findings. So let's think about how to interpret these and what our next step should be in this patient's care. So let's go to the next slide. All right, as you may remember from our prior session, interpreting mutations can be really difficult, especially as you're learning. And fortunately, we have really helpful bioinformatics tools to help us. And the Stanford HIV database that I linked to last time, and you can see on the screenshot here, is a really useful way to remind yourself of what different mutations mean and sort of what the implications are. And just as a reminder, the way it works is you plug in the genotype resistance findings into the web database, and it will give you an interpretation of the results. And we have interpretations based on different drug targets. So this first set of data relates to mutations that are relevant for reverse transcriptase. And we have mutations that affect both NRTIs and NNRTIs in this case patient. And they're oftentimes when you do this kind of testing, you will detect a number of minor mutations and also polymorphisms that don't clearly affect drug susceptibility. So we see all of that data there, and the key is sort of what's the most important findings to see. I think the mutations to highlight in this patient are the NRTI mutations K65R, which is sort of the classic mutation for tenofovir resistance, and M184V, which, as we discussed last time, is a key mutation associated with lamivudine and M-tricytidine resistance, but has the funny property of rendering the virus less fit as it's replicating. And then on the NNRTI side, we see a K103N, which is a classic signature mutation associated with efavirenz resistance and also resistance to other NNRTIs. So it's not at all surprising to see this mix of mutations in a person who has received tenofovir, lamivudine, and efavirenz for prolonged periods of time irregularly. We don't know exactly how this patient was taking these medications, but clearly this is an individual that was in and out of care and for a prolonged period of time. So really for perfect situation for developing drug resistance. And then I have an animation here, if you can click forward. There's the possibility of sort of quantifying the resistance in a little bit more detail. The database program will give you a numerical score to try to figure out how concerned you are about drug activity in a particular case. Higher numbers are worse, so it means higher numbers are associated with less activity of the drug. And I'm including these here really just for interest, and with the key at the bottom, so you can see that this patient has sort of intermediate resistance to tenofovir, high level resistance to efavirenz, high level resistance to lamivudine. So really that prior regimen of tenofovir, lamivudine, and efavirenz is not expected to have useful activity in this patient. And you can see that multiple drugs are affected, unfortunately, in this individual. You'll notice that the number for AZT is actually negative. And we talked about this briefly in passing last time, and sort of this interesting phenomenon that certain mutations, while they may make one drug less active, may have the opposite effect of making another drug more active. So that's one of the interesting effects of the K65R and M184V mutation. So AZT is actually still well active in this patient's virus. Okay, let's look at the next slide. Interestingly, this patient also had a minor PI mutation, despite not having any sort of described history of receiving protease inhibitors. Hard to know exactly what to make of this. This isn't this very common one that we'd see in the United States. It's conceivable that this was, a transmitted mutation, but overall wouldn't make too much of this finding. Certainly not a major mutation. So let's run the numbers for the interpretation as well, like we did before. Perfect. And you can see that there's very minimal effect on the protease inhibitors mentioned here, atazanavir, duvernavir, and lopinavir. Okay, so that's some of the interpretation data that we have from the database. So let's think about what to do next. Next slide, please. So before we start thinking about drugs, mutations aren't the only factor, and for those of you who are involved in clinical care are very familiar with this. But just as a reminder, as we're thinking about ARVs, it's not just about a matter of resistance. It's important to know whether the patient has concomitant hepatitis B. We certainly want to retain something that's active against hepatitis B, ideally tenofovir for those individuals. Thinking about comorbidities and other medications, of course, is important as you think about minimizing toxicities and avoiding drug interactions. And then, we talk about this patient as struggling with adherence, but I would say that may be important to call out, but it doesn't really help us too much because there are so many reasons why patients struggle with adherence, some of which were sort of outlined in the prior discussions. But, now we're thinking about a second regimen choice for this patient, and the question is like, what have any of those factors been addressed, and how can we set this patient up for success and avoid repeating some of the problems that led to the failure of the first regimen for this patient? And in particular, one thing we might need to think about in the context of salvage therapy is whether any of the second-line drugs that might be given more than once a day are really realistic options in our patient. It's fine to design something that has in vitro activity, but if your patient is just frankly not going to take a twice-a-day drug, it's not very helpful to prescribe such a thing. So we really want to take a practical approach and try to understand what went wrong the first time and try to avoid that going forward. Okay, next slide. So now we've got a voting opportunity. I will say that for this question, there is one clearly wrong answer, but there are also many other possible alternative answers. And I'd love to see what this group thinks. So again, young patient, as far as we know, doesn't have comorbidities. We're not told anything about hepatitis B, so let's assume that he does not have hepatitis B. He has failed tenofovir. Well, he had treatment failure with tenofovir, lamivudine, and efavirenz, and now the question is, what should we do? We have mutations in for M184V, K65R, and then K103N. So what would be some possibilities here? Let's give everyone a minute. So don't be shy. I hope everyone votes. Maybe 10 more seconds, and then we'll see what the group's thoughts are in this question. All right, why don't we see what the numbers look like? Michaela, can you finalize the poll? Okay, so interesting. We see a strong preference for dolutegravir-based regimens. I like that. And actually almost an even split between a tenofovir and an AZT backbone, with a smattering of other choices. Interestingly, I see tenofovir, lamivudine, and efavirenz being chosen, and that I think is the choice that would be the most concerning, because none of the components of that regimen are active for this patient. That patient, I unfortunately wouldn't benefit from ongoing treatment with that combination. Would anyone, and so I'd really like to make this as interactive as possible. I'd love for someone that chose A to share with the group why they chose that option. If anyone is willing to go on speaker or at least text.
So any volunteers from our participants, from those who answered? Okay, Mark is the attending.
Okay.
Did you answer A, Mark? So John is asking for those who answered A to say why they answered A, but please share.
Yeah, and now I'm ready. Okay. Dr. John. Yeah, I answered A, not because I'm the attending, I'm the one who prescribed this, but because of several reasons. One, the tenofovir lamivudine dolutegravir regimen is a single dose regimen, so single dose formulation, so it would be very convenient to the patient who has a history of non-adherence to medications. Number two is, despite the tenofovir resistance and intermediate resistance, I think the regimen would still be very effective given that the patient is on an integration inhibitor, and evidences are available saying that you can still recycle your NRTI despite the resistance pattern, as long as you are on the dolutegravir or you're an integration inhibitor. I think those are the two reasons why I chose A.
That's great. And we'll talk a little bit more about the recycling data, but that's totally agree. Would someone who chose D like to share their thoughts about that choice?
I'm calling on anybody who answered D, Delta, zidovudine, lamivudine, and dolutegravir. Would you like to share why you chose letter D? Okay lang, don't be shy. Okay, no one is volunteering, John.
Okay. That's okay too. How about does anyone else who hasn't spoken up want to share their thoughts? Again, this is not to criticize or make anyone feel bad, because I think there are many different ways of tackling this problem. Some choices I think are easier for the patient to take or potentially less toxic, but there are many different ways to potentially treat this patient's HIV.
Yeah. So anybody who'd like to share why they chose their particular answer, share lang. We want to hear your voices, your beautiful voices. Meron bang available? You can raise your hand or unmute yourself. My gosh, very shy. Is it okay for me to call on someone? Oh, I some names are familiar. Why don't I call on my friend, Dr. Jelza Zabat? I see your name. Are you free to share your choice? Or what would your choice be?
Hi, Dr. Kate. Hi, Dr. John. My choice is the same. It's A. As
Okay.
what Dr. Mark said.
I see.
Patients are really compliant with a single pill daily regimen. That's the main thing. So I have the same answer. Thank you.
All right. Let's take a stab at hopefully not a letter A. Can I call on Joe Poblete? This is the last last call. Joe, can you share with us your answer?
Letter E, ma'am.
Oh, okay. Sorry, John.
On the basis of the key 103.
Okay. Thank you. So I don't think I'm a good gambler, John. I seem to be getting all A's now.
That's okay. Well, you will get a chance to vote again after we chat a bit more, and we can see if there are other thoughts. I think it's really interesting that no one said G or H, so everyone made a decision. That's great. All right, let's move along then. I don't mean to torment everybody with this. All right, next slide, please. All right, so basically there are sort of two types of strategies that I offered to you in that menu of choices. And I think the most conventional way of building a second line regimen would be to think about retaining some NRTIs and then changing from an NNRTI to either an integrase inhibitor or a protease inhibitor. So let's talk through that option a little bit further. Next slide. So I'm going to share some trial data with you, and the reason for doing this is not to sort of get overly focused on the particulars of individual trials, but just to sort of share with you what we know from studies that hopefully are relevant for your clinical practice. And these are referenced on the slides, and if you need copies of the papers or want to discuss them more, I'm happy to do so offline. So when we think about salvage therapy in the context of relatively limited drug choices, I think the Dawning trial here actually has a lot of relevance for clinical practice. So this was a RCT that was done as a non-inferiority study in multiple countries, and this was comparing second line therapy with either ritonavir boosted lopinavir or dolutegravir paired with NRTIs of the investigators choosing. So, patients were randomized to either dolutegravir or lopinavir-based lopinavir-ritonavir treatment, and then the study clinician could choose whether that patient was going to continue tenofovir or switch to an AZT-based backbone. So there was flexibility in that regard. Of note, these patients did have genotyping at baseline, and persons who had baseline resistance to integrase inhibitors or protease inhibitors were excluded. And that's information that we may not always have, depending on the resources that are available. So it's good to have that context for the study. And so these patients were randomized into these two different arms, and it was found that there were similar rates of viral load control after a year, week 48. And in fact, dolutegravir was statistically better than lopinavir ritonavir in this study, with overall viral load suppression of about 84%. So very encouraging to see this. Let's talk about it a bit more. Next slide. Just to say, when we're looking at studies, we always want to look at the patient population and try to determine how generalizable they are to the patients that we're taking care of. So these were pretty young patients in their 30s, mostly men, some of whom had more advanced HIV, stage C. Small number, relatively small numbers had high viral loads over 100,000. CD4 counts under 200 were relatively common. And like our case patient, large numbers of these individuals had been previously exposed to efavirenz. So that's sort of summarized on the left-hand side of the slide. The graphs on the right side of the slide just give you a sense of what types of mutations were present. So you can see that many of these trial patients had the M184V mutation plus another NRTI mutation. That's very similar to our case patient. And then interestingly, most of these patients had less than 2 fully active NRTIs in their salvage regimen. Okay, next slide. So this is just a little bit more information about response based on the mutations that were present. And you can see that if we're just looking at that very common mutation, M184V, persons who are treated with dolutegravir or lopinavir or ritonavir both have high response rates. Again, sort of dolutegravir looking a little bit better. And when we look at when there's even more resistance with M184V plus other mutations, the response rates of dolutegravir remain quite high. It gets a little bit tricky to interpret some of these results because, as I mentioned, in this particular study, there was variability in the use of the NRTI components of the salvage regimen. But I think the take-home message is that when we're thinking about second-line therapy, dolutegravir performs very favorably to lopinavir or ritonavir based regimens. I think that's all I want to say about donning for right now. So let's go to the next slide. The other trial that I think is really helpful to know about is this study called the Nadia study. This was published initially in the New England Journal several years ago, and then more recently with longer follow-up in the last year. And this really sort of took the results of donning and built on them, and I think in an even more useful way. So this again was a study of second-line therapy, in viremic patients, and sort of the key difference from donning is that a different protease inhibitor was used. So instead of lopinavir or ritonavir, darunavir ritonavir was the PI. And so patients were randomized to either of those. But then there was an additional randomization to the NRTI backbone. So within the dolutegravir group, you could either be on a tenofovir-based backbone or an AZT backbone. And similarly for the PI regimen. So a little complicated with all those groups, but helps us better, I think, answer the question of which components of second-line HIV therapy are, most critical and what and should be chosen. And again, this was a non-inferiority study where the goal statistically was just to show, whether these approaches were similar or not. And the goal was to look at viral load control initially by week 48 and ultimately week 96. And what we've seen at week 48 was that the two arms were similar overall. But what was concerning is that there were some cases of dolutegravir resistance that were detected overall in this group. Let's move along to the next slide. Again, sort of look at the results in a little bit more granular way, sort of the patient characteristics. These are patients that had relatively limited experience to ARVs, as opposed to some of the studies in the US or Europe, where often patients are on ARVs for longer periods of time. The K65 tenofovir associated tenofovir resistance associated mutation was common in this study, along with M184V, and you can see that with those numbers. And resistance overall. Next slide, please. These are sort of more detailed results. Again, as I mentioned, at week 96, both dolutegravir and darunavir-based regimens showed good efficacy. And interestingly, when you looked at the NRTI backbone, being on a tenofovir-based backbone seemed to be a little bit more efficacious. As I mentioned, there were some cases of resistance to dolutegravir that emerged in the study. Next slide, please. So things to take away from Nadia. are that, for second line therapy, dolutegravir looks quite robust. Despite the presence of K65R, you don't have to switch over to an AZT-based NRTI backbone. You can retain tenofovir. I think from a programmatic level, one of the concerns is, if you are doing this routinely, how much resistance will you see emerge? So that gets back to our earlier point, is you really want to set this patient up for success with the second line regimen, because I think especially with imperfect taking of the pills, you may compromise additional drugs, and you would really want to have close monitoring of adherence in this setting. Good news for dolutegravir overall with that caveat. And then I think what was helpful was to see that tenofovir looked to be a robust choice, and we don't have to use AZT, which carries so many adverse effects with it in these patients. Next slide, please. So heavy on the data, I want to sort of take us through a little bit of one of the alternative approaches. So in the US and elsewhere, as we're dealing with aging patients that have more comorbidities and often have accumulated drug resistance, we have a lot of interest in alternative regimens that minimize toxicity. And I will say, many of my older patients have renal insufficiency or osteoporosis. So even though we love tenofovir as a very good antiviral, it certainly has toxicity concerns. And in some situations, we're looking for opportunities to avoid using NRTIs and tenofovir. So one of the strategies to accomplish that is by dual therapy with a protease inhibitor and an integrase inhibitor. And this has been looked at for several different drugs. So let's take a brief tour of the data that's there. Next slide, please. I think the study that we're that's catching most of our interest these days is this Dualis study. Things to know about it. So this was a switch study. So this was a study looking at persons who were already virologically suppressed. And the question was, if you switch them off of NRTI backbone to a dolutegravir backbone and continue darunavir, how did they do in terms of viral load control? It turns out they did really well. Next slide. Michaela, next slide, please. So by 48 weeks, very similar levels of viral load control were seen in these groups. The approaches were felt to be statistically quite similar. Patients in general tolerated the two-drug regimen well. There were some changes in lipids between the groups, and this is sort of talked about a lot when we think about TDF and TAF. TDF may have some lipid lowering effects, and when you take it away, lipids look a little worse, so that may be part of the story. And encouragingly, this two-drug approach of the integrase inhibitor and protease inhibitor not only was effective, but resistance to that regimen wasn't seen. So this is becoming an alternative for some of our patients. So I will say that you can't necessarily apply this general principle of choosing any integrase inhibitor with any protease inhibitor, because they are not all created equally. And let me share some of those other data with you just to get a flavor of that. Next slide, please. So other combinations have been studied. This is an earlier trial looking at boosted darunavir plus raltegravir, so one of the earlier integrase inhibitors. This was actually a treatment naive study, so instead of a switch study. And overall, for the study, the two-drug regimen did okay, except among persons who had the lowest T cell count or the highest viral load. So the two-drug regimen was statistically worse in CD4 counts under 200, and there was a trend towards worse outcomes for viral loads over 100,000. And concerningly, there was also emergence of resistance to raltegravir. Remember, raltegravir is twice a day, so the adherence concerns can definitely be more of a factor. And raltegravir does not have as high of a genetic barrier to resistance. So not surprising that this approach was not as effective. Now, let's think about regimens that are a little more compatible with what's available in the Philippines currently. There are some limited data about lopinavir and integrase inhibitor dual therapy regimens. There's a small study published in one of the California collaborative cohorts some years ago. And this included about 50 patients total, so quite a small study. There were when you looked at dual therapy with the integrase inhibitor compared to NRTI backbone, integrase inhibitor therapy led to faster viral suppression, but when you looked at, but by week 48, the results were very similar. It was overall just a very sort of preliminary study, but there were some signals of challenges with adherence in the raltegravir group, not surprisingly, given the twice daily dosing. Next slide. There was a larger study of lopinavir dual therapy called Progress, again, showing pretty similar results to 3-drug therapy. I will say that this study is concerning because the overall rates of viral suppression at a year were relatively low, so 66% instead of the 80-90% that we're more used to. And concerningly, in this study, there was development of drug resistance to not only raltegravir, but also the protease inhibitor, lopinavir in this case. So not particularly attractive, I would say, for this combination. Next slide, please. So we reviewed some of the data for informing our choices of second-line therapy in 2023. There's, of course, still a ton we have to learn about it. And I'm wondering, based on all this, if you might choose something different for our case patient. So we'll give you 30 seconds if you like to make a choice. And Emma, thank you for sharing those references in the chat. And Kate as well. Yeah, why don't we see how the results look at this point? So let's finalize the poll. All right, well, I think we've converted a few people to the Nadia data. I will say that WHO guidance has not yet fully caught up to the results of the Nadia trial, and so the AZT-based backbone is often still suggested among persons who fail a tenofovir-based backbone. But I'm hoping that there'll be reconsideration of those recommendations in the short term. Great. Well, I'd love to hear, everyone's thoughts about these data and sort of your own perspectives and approaches as you're handling these cases in your clinics.
John, do you mind if I call on again Dr. Pasayan to ask if what the current regimen is now and how the patient is actually faring?
That'd be terrific. Yeah.
Hi, good morning again. Yes, so we started him on tenofovir, lamivudine, and dolutegravir with good adherence, and on repeat viral load, we were able to decrease it down to around 700 plus. So it's already suppressed, but not yet undetectable, based on the new definition.
That's great. I'm glad to hear that he's responding.
Yeah, so that's another nugget of information, John, that maybe on later sessions we'd like to share with the group, is that there are 3 recommended classifications or categories of viral load. We have the undetectable, the suppressed, and the detectable, but the implications of which are still positive, as viral loads less than or equal to 1,000, according to WHO, have what they call negligible risk, of transmission, while those who are undetectable, as stated in their viral load results, have zero risk. So there's a lot of mixed feelings about that statement by the WHO, but we're free to discuss in future sessions. Thank you.
I would say in this patient, given the concern for developing dolutegravir resistance, this is a patient we definitely would like to see be completely undetectable. And so I would worry greatly if he maintained viral loads in the hundreds.
Okay. All right. Thank you. John, are there any more slides after this?
Nothing that we have to share. I had some extra slides.
yes,
You know what? I forgot
Let's go
myself.
ahead with the summary points. Yeah.
I think we've hit on all these, but we talked about dolutegravir being a robust choice for second-line therapy, and there are ongoing discussions about what the backbone should look like, and some concerns about developing resistance to this incredibly useful ARV, and for wanting to make sure that we're monitoring folks carefully so that we don't lose this really useful tool. I guess would also state that sort of dual therapy is a ongoing interest, and I think NRTIs are going to remain an important component of our regimen. With dual therapy, I think you have to be really cautious, and I think still an NRTI recycling approach for salvage makes sense in most patients, but there will be some patients who have end organ complications or other extenuating circumstances where you truly do want to remove NRTIs. I think you just need to be really cautious about extrapolating two drug regimens to all members of those drug classes, because lopinavir is not as robust as darunavir in terms of its resistance barrier, nor is raltegravir compared to dolutegravir. So be really careful, with how you're extrapolating the data that's out there. And in general, wouldn't recommend INSTI and PI approach if you have a patient with a CD4 under 200 or a high viral load over 100,000. Yeah, we don't need to do the additional slides. I put in some additional data about lopinavir versus darunavir in case there was interest, because I think that was one of the questions that came up. But I think it'd be more interesting to hear from the group about perspectives on salvage regimens.
Great. All right. Thank you so much, John. That was very interesting and enlightening for most of us. So that's new learning for us guys today. And thank you so much also to Dr. Mark for sharing today's case. And I hope that our patient will eventually reach the undetectable state. It is at this point in the meeting wherein we're going to spend the last minutes of today having our Q&A, and I'd like to introduce you all to our facilitator, Dr. Janice Kawili, who is my co-lead for complex medical management QI learning sessions. Over to you, Dr. Janice.
Okay, can you hear me?
Yes, loud and clear.
Okay. So thank you very much, Kate, and thank you, John, for discussing that case with us, and thank you to Ilde, to Mark, and to all who participated earlier. We have actually, so I'll be moderating the Q&A. Earlier we had a question from Dr. Roman, and this is regarding, and maybe Ilde, you can have additional comments. Bruce actually had some answers in the chat box, but the question of Dr. Des is, do we need to collect data for all problems? Like for problems that are too obvious, do you still need to collect data, not for purposes of identifying problem, but for baseline data to be used for monitoring success? Well, just to mention, Bruce actually already said that for this project, data collection will focus on the network indicators and relevant characteristics that we need, of course, for the project, and that we need to track these data specifically for the network. So, but can you add to that, Ilde?
Actually, I agree with Bruce. No, so another sort of thing maybe is that I haven't added in the features of a right problem identification is that if the data is very obvious enough, however, the question there would follow is, was it documented? Was the data used to an improvement project? If not, so maybe we need the data. And I agree with for this network, we need to have the data that have set by the measures. And again, another content of the question maybe is, do I need to data for the baseline? Yes, data for the baseline is very important. Although it's obvious, but again, if that was the obvious data, but that was translated for quality improvement, this is the time to make it be useful. So that's my piece on it.
Okay, thank you,
And
Ilde.
Janice, I would
And
just,
I saw Bruce there. Okay,
yeah.
Bruce, you can.
I would just
can answer.
add that, I think Ilde gave us a really nice example of the long view of data and where we will go over time as we measure improvement. And right now we're at the beginning where we're just learning, what the baseline is, and then over time we'll be plotting the run charts and looking at performance. And then the other thing is that there will be a distinction between tracking the indicators and then measuring the actual test of change that's made and whether that's put into practice. And I think we can go into clarifying those different types of measurements and when they're used in a subsequent session. And importantly, it will come out in the individual coaching sessions that Ilde does with each group. So thanks.
Thank you, Bruce. Okay, I think the next question will be for John. Although I don't see any questions in the chat box, I have a question for you. You actually included an option for dolutegravir plus loperamide in the for that case. Although you said that you have slides for this, and I think it will be interesting for us to know, what are your thoughts about that combination? Just giving dolutegravir plus lopinavir, ritonavir. And I think the reason why you included that is because we don't have raltegravir. Before we had that, but then it's not available anymore. We don't have darunavir, ritonavir in the Philippines. We have lopinavir, ritonavir, and dolutegravir, and you actually included that in the in the options. Can you please comment on that? Using that combination for as a salivary.
It's a great question. I think one of the challenges, I didn't see any literature with that specific drug combination. We see lopinavir with raltegravir or dolutegravir with darunavir, but sort of don't know about this other choice, and that's always one of the challenges with ARV management. I mean, I think I would feel more comfortable with lopinavir plus dolutegravir compared to lopinavir plus raltegravir, because you could give the entire regimen once a day. So adherence would be a little bit better in that regard. Certainly in principle, it should be a very robust regimen. I would, again, have some concerns for a patient who had a particularly low CD4 count or very high viral load, because those are really sort of the stress points with the ARVs in general. I guess I would want to know the specific circumstances that would motivate that particular choice, because I think the Nadia data are pretty compelling that you can get good outcomes with retaining the NRTIs, and in most circumstances wouldn't need to shift over to that PI lopinavir dolutegravir dual therapy approach. The other thing I think you could consider in the Philippines, because you do have rilpivirine, is that our case patient, you potentially could have given that patient tenofovir, lamivudine, rilpivirine plus dolutegravir if you wanted to strengthen that regimen a little bit. I just hate lopinavir in general from like a metabolic standpoint and a tolerability standpoint, and it's just such a difficult drug for patients. It's a good good antiviral, but metabolically pretty awful. And I think if this patient, I'd love if this patient was already not taking meds regularly because of perceived side effects, I think giving that patient lopinavir, ritonavir is not going to facilitate adherence. So the answer is I don't think we have data to inform that combination. I could imagine that it could have value in some circumstances, but in general, I feel pretty happy with the NRTI plus dolutegravir based approach for salvage.
Okay, so
Also-
that's another regimen that was that's introduced now, giving tenofovir, lamivudine, dolutegravir, and add rilpivirine. Is that correct, John?
Yeah, you that could be an option. I think the key things with that is, rilpivirine is, is a relatively low barrier to resistance. You're supposed to take it with food. You can't use strong antacids. So I think I would worry if there were stockouts or the patient was selectively non-adherent, that you could lose more components of that regimen. If the patient was willing to take the regimen with food and seems like they could get those meds reliably, that could certainly be a little bit more of a robust choice compared to what was done in Nadia, but hard to say. I mean, in the US for a while, we were often doing similar combinations where we have a lot of co-formulated drugs that I think are not as available internationally. So we have, tenofovir, emtricitabine, and rilpivirine as a combination drug, and that can be given, for example, with dolutegravir. So I feel a little bit better with some of these combinations when I know we can give them co-formulated because we have more assurance that everything will be taken together. So yeah, as we mentioned, many different ways of doing it, and adding rilpivirine to that mix could be more robust. It could be another way to do things.
So and also, I'm not sure if it was mentioned during the questions, but if we have difficult cases like this, and the doctors are not confident to just retaining tenofovir, lamivudine, and adding dolutegravir, replacing the efavirenz component, they actually add lopinavir, ritonavir. So there are patients in the Philippines who are on tenofovir, lamivudine, dolutegravir plus lopinavir, ritonavir. Can you please comment on that regimen?
Probably overkill, unless you've got hepatitis B co-infection. I mean, it'll work, and we sometimes will do a similar approach for our patients who really struggle with adherence, where we will give them something that seems like it should be way more than is necessary to control the virus, with the thought that if they're imperfectly adherent, maybe that will be more robust. You also reach a point, though, I think, where you get diminishing returns when you keep adding things to your regimen, especially if you're adding things that have more side effects and toxicity. So I can understand why someone might do that, and certainly it goes against our thinking a little bit to retain drugs that look like they're resistant. With the case of tenofovir, what we talked about. It's certainly not a wrong approach, but you are adding pills and adding toxicity, and I think in most circumstances that might not be the best strategy. But I could certainly understand why someone might choose that.
Yes. Oh, thank you very much. And there's a follow-up question, John. Regarding the case that was presented by Dr. Adtuon, is there a threshold for shifting to TDF, or rather shifting from TDF to say dovudine just because of increasing creatinine or decreasing creatinine clearance?
Yeah, good question. I mean, the package insert suggests that TDF shouldn't be used if the creatinine clearance is less than 50. I mean, I think you certainly want to look at the trajectory of the creatinine clearance. If someone is having, fairly rapid changes in their creatinine that aren't otherwise explained, and they're on a TDF-based regimen, that would certainly give you pause. But for someone that is already having moderate renal sufficiency with a creatinine clearance around 50, that's usually a person where we would not want to give TDF. I think we're recognizing that threshold is probably a little bit conservative, but that's the number that's usually cited.
Or is there an option to observe, not to shift immediately? For example, review the medicines, the other medications that
Yeah, for sure.
that
No, I
patient
think
is taking, for example.
I think if you can monitor the
shift-
patient carefully, I think if you are seeing a patient who lives in a remote area and it's not possible to get labs done very often, then I think the way you handle that is different compared to someone that is in the urban area and is well connected and can get lab testing in a month. So
Yes.
No right answer, but I think being conservative, if you can't monitor the patient, closely makes sense.
Okay, so thank you, John. And of course, this is also in relation to what was mentioned earlier by Ilda about monitoring of response to treatment. What's your recommendation? When should they repeat a viral load? When they change regimen?
Certainly I'd want to, I mean, in the US, what we would do, with more resources would be, certainly check a viral load when we switch, and often check it monthly until they're undetectable, for the folks where we're most worried about how they'll respond to that regimen. So our tolerability for low-level viremia is very, very low these days. So because we have easier access to the testing, we do it more often. But I think there's a really strong case to be made for more intensive follow-up in these cases that are being, where you've already had multi-class resistance and virologic failure, and you don't want to lose additional options. The case patient, I'm glad that the viral load's down to 700, but I think if it's not monitored carefully, we could easily use dolutegravir. So I would, in a more resource setting, check a viral loads, 4 to 6 weeks after that 700 value to see where things are going.
Mm-hmm. I see Kate. Kate raised her hand. Kate, can you ask your question? There are actually a few more questions here, but you can go ahead, Kate.
Thank you. So this question is related to the future of the HIV program. So in the future, not yet now, we are supposed to achieve an 80% switch from patients on legacy drugs to TLD. It's because of supply and cost efficiency for the government. And what your statement earlier as to repeating viral load as soon as you switch for patients who are already suppressed, undetectable on their old regimens, but then switch to TLD because of a program issue, knowing that dolutegravir has a higher genetic level of resistance, do you still advise us to switch everyone who's going to shift towards that to do a viral load?
I'm sorry, I got distracted by the chat, Arthur's question. Do you mind restating that question? I'm sorry about that.
Okay.
For those who are suppressed on legacy drugs,
Sure.
but who are going to be shifted to tenofovir, lamivudine, and dolutegravir as an instruction from the local government, do you still recommend us to do a viral load?
I think if the person has a clear track record of success with their prior regimen, it's not as critical. I mean, as a ID specialist, I will always say more data is good. But we have to recognize that our resources don't always permit that. So I think it's a different situation if the patient's doing well and stable on their current regimen. Certainly, we see very little integrase resistance in persons who haven't been exposed to integrase inhibitors in the past. So if the person was doing well on a efavirenz-based therapy and hadn't taken an integrase-based regimen, I would expect them to continue to do well on an integrase-based regimen. So I wouldn't be overly nervous about having to do very short interval follow-up, but again, with more resources, we do commonly check viral loads pretty soon after regimen changes. And in my US practice, I would typically check a viral load and full blood count and creatinine and LFT is about a month after any type of regimen switch. Again, probably overkill in many situations, but that would be our common practice, I think.
Thank you. So just to summarize, if we had enough resources, a month after a switch, any switch, we should ideally do a viral load among other stuff. But for a resource-limited country, if a person is doing well on lamivudine, tenofovir, and efavirenz, and you're just shifting efavirenz to dolutegravir, we can be not so scared to do a quick viral load and just do the usual once-a-year viral load.
Yeah, I think that once a year always makes me a bit nervous, but correct. I think within the limitations that are present, that sounds possible. You know, I think you can always, there's always a little bit more forgiveness and latitude for in cases where folks are already undetectable. It's very different if you're starting with a high viral load. So I agree with you.
So thank you, Kate, and thank you, John. Okay, this is actually a follow-up question before we. It's still related to the case that was presented earlier. So this patient had low creatinine clearance while on TDF, shifted to AZT, and had anemia. So can we resort to an NRTI sparing regimen even if the CD4 count is still low and the patient is not virally suppressed? You actually answered that question already. You said that you would prefer that the CD4 count is above 200 and the patient should be virally suppressed. But the question is, you know, has the patient has anemia with elevation in creatinine, and we don't have 3TC and a bacavir combination in the Philippines. So can you comment on that?
Well, I wouldn't necessarily be dissuaded from trying tenofovir again. I think that, you know, there's so many things that could affect renal function in our patients. And I especially in a younger person, you know, I wonder if dehydrated, you had some rhabdomyolysis, or they used a bunch of ibuprofen or what have you. You know, I think that would be my first comment, is that I wouldn't necessarily give up on tenofovir at this stage. You know, we get in this patient, abacavir is also not going to be fully active because the M184B affects that activity to some extent as well. So this is one of those situations where you could take the case different directions. I think we don't really know. We don't have any long-term data on dolutegravir plus ritonavir boosted with lopinavir. If you chose to use it in this patient, I'd only make that choice if you could ensure that the patient's going to have, you know, post viral load follow up. I think that's you know, in an adherent patient with close follow up, maybe. I'd be a little nervous, but maybe. Sorry, I can't give a more definitive answer.
Thank you, and you already answered the question of Dr. Des. Okay, so thank you. Okay, so I have a question for Ilde and Bruce. So earlier, when Ilde asked the group not to just put in the questions, why, and I actually counted several. So they had several whys, Ilde. Poor compliance, lack of supplies, and then they also had a why. They have financial constraints. It's a reason why, or even there was a suggestion that drugs were less effective because of, you know, poor storage of the drugs. So now they have identified all these concerns. So how do they now, you know, put this into their QI activity in the clinic? So they identified several whys. So how can they use this information now to, you know, to use to improve their practice? So will they answer all of those at the same time, or should they prioritize? So can you help us? Can you help us, please? How to, you know, to navigate through these whys that were actually, you know, raised in the chat box.
Yeah,
but the most common, by the way, Ilde, number one is for compliance. But there were also other whys that were shared by our participants.
Yeah, thank you very much, Dr. Jonas. That was a good question, actually, and thank you for wrapping up actually what I missed in my part. Okay, so what's the best thing to do for that is ask another why. For example, whether low compliance, another why, because that would reflect to maybe the behavior, or we have a reported discriminatory environment. Another why, how did it happen? Another why, until we exhaust all the whys. And after that, we will look at for the root cause among the causes. And when doing that is doing prioritization and also looking at the very important thing in the problem and root cause is this cause within our control. because some costs might be outside of our control. So that's my piece of advice, and it will be part on the next session. Okay, Bruce?
Thank you, Ilde. Okay, Bruce, you're muted.
Yeah, thanks. Yeah, I was just going to suggest that we focus in on this very practical question at the next session. And I think, as Ilde pointed out, it's helpful to think about system level or policy level factors that are not within the control of the clinic to use their QI work to improve. And that a great example of that was this genotype reporting example that came out of the network last time. But then there will be other issues that come up that are very much part of the clinic systems processes. So we're really talking about two different kinds of root cause analysis. One is kind of the big picture root cause analysis, which gives you these different factors, and that's where the fishbone comes in quite handy, I think, as Ilde pointed out. And then there's that level of breaking down the specific issue with what Ilde was talking about, the 5 whys, where it's like we want to say, okay, so why is there a problem with adherence? And really breaking that down. Why does the patient have a hard time taking their medications? Why can't the patient get the medication? And then you may uncover that there's a transportation issue, a financial issue, whatever. But that's like a second step to the larger root cause analysis. And I think it would be great, again, if we have some practical examples that we can draw on, hopefully from one of the participating sites, that then will allow us to really tease out some of the practical issues, just like we do with the clinical cases. Thanks.
Yes. So yes, I agree, Bruce. So it's very interesting. No, we have this case, we have management, but we also look at different factors that actually have an effect on these clinical concerns. So I'm really happy that we're learning this from this network sessions. There's actually a comment from Emma, and this is still regarding the case. While talking about renal function, it's worth reminding everyone that dolutegravir artificially raises creatinine by inhibiting tubular secretion of creatinine. It does not actually reflect worsening kidney function. So if a patient is switched to a dolutegravir-based regimen, a small bump in creatinine should be expected. On average, around 0.1 milligrams per DL. Thank you very much for that, Emma. But do we expect this to actually resolve, like within a few weeks? What should we do next? Just maintain the patient on tenofovir and then repeat the testing. Emma, you can open your video and microphone.
Sorry, my connection isn't great, which is my camera is off. That change in creatinine may maintain while you stay on the dolutegravir-based regimen. So I mentioned that just as one of the considerations if you're concerned about a creatinine rise, and with that question about whether or not to reconsider tenofovir, there are a number of other potential culprits. So it would not be unexpected to see that rise, and you would expect it to stay that way and be sort of an explanation for a stable change over time.
Okay, so thank you for that information. Okay, we don't have any more questions here in the chat box. I'm sure our participants have maybe questions that they have not yet shared with us today, but of course you can always send that to us, and we'll try to to ask our faculty to comment or answer your questions. So that's it for me, Kate. Sorry, it's 11:02.
Thank you so much. And in the interest of time, I would like to keep everything short. So first, I'd like to thank everybody for staying on for the whole 3 hours for today. And I'd like to inform you all that we will resume our mentoring from this point on until our next network session, which is going to be in 2 months. So sometime in November, late November, we'll see each other again, and hopefully more participants can share their experience with their QI process and their cases also. We'd like to thank our speakers, Sir Ilde, John, of course, our moderators, Ma'am Janice, our case presenter, Jonah Antuon and Mark Pasayan, Emma, of course, and everybody who joined us today. And we'll see you all in 2 months. Good luck, everybody.